I'm Alon Harris, and I am delighted to be invited and honored to speak on behalf of the Indian Ophthalmological Society and Indian Glaucoma Society on optical coherence tomography angiography, OCTA, for detecting ocular blood flow. And today we'll focus mostly on glaucoma. I will give you a background, in historical perspective of how it's tied into the OCT. We will talk about studies that show the relevance of OCTA to glaucoma. We will show the relationship between structure and function in terms of blood flow. And then we will also suggest that perhaps OCTA could be used to detect other systemic diseases. Thank you. This is my international collaboration worldwide, where we've been studying ocular blood flow and glaucoma for several decades, all the way from different technologies to different medications to imaging to high resolution to mathematical models, artificial intelligence, as well as combining different models for detecting systemic diseases. This is my financial disclosures, and the studies have been supported by NIH, NSF, RPB, and New York Eye and Ear and Infirmary. Glaucoma, as you well know, is a multifactorial disease, many different risk factors, but only intraocular pressure is approved by the regulatory agencies for treatment. Yet, many different vascular risk factors, depending on your genetic predisposition, could be very important for the prevalence as well as for the progression and incidence in glaucoma. And today, I want to focus on new technology after the concept had been suggested already as early as 1800 by von Graefe, later on by Jaeger and Smith, and suggest that the advent of new technologies really helps us anchor the importance of imaging and measuring ocular blood flow as it's related to glaucoma. Now, those of you that have followed the field know that there's been many different ways and attempts to look at ocular blood flow in the back of the eye. And this has been a fascinating journey. And what I was really trying to look for is how do we combine structural changes and function changes like visual field to actual blood flow measurements in the eye, in human eyes. So I asked the question for today's presentation on your behalf: is OCTA really ready for the clinic? And to do that, I'm going to give you a historical perspective, talk about principle of operation, and of course, put it in relevance to the OCT, which is the background methodology of OCTA. And I'm reminding you that when we talk about OCT, we're talking about the layers of the retina, which have different indices of refraction. The infrared light from OCT, or the acoustic waves, the B scans, are emitted by the eye. And the unique backscatter from layers of the retina are observed to measure the optical reflectivity. And this is the original publication schematic, which I share with you here since 1991. And you will see the major developments since. This intelligent audiences we're familiar with, basically example of an OCT exam. The different refractivities of the layers of the retina grant us to an in vivo non-invasive cross-sectional view of the retina. Current depth limit is between 2 to 3 millimeters. And one of the biggest drawbacks or omissions in these scans was the lack of imaging of microvasculature, which is, I hope to show you today, is quite encouraging and possible. So over the years, the OCT has gone through different developments and continuously enhancing the scans, further isolating valuable data from the poor resolution artifacts. Most modern OCTA devices are built on spectrometry and swept source techniques, and the transitioning to OCTA through subtracting the information from subsequent scans helps us produce a resulting decorrelation signal that represents flow. And you can see this beautifully here. The only movement detectable in the eye is from blood flow in the eye, okay? So when subsequent scans are taken, these changes that are visible should be coming from blood flow. When artifacts are dealt with and ignored from patient, technicians, environment, or equipment, and the decoloration signal is due to one of the two things, amplitude decoloration and phase variance, which is shown here with this cartoon for your convenience. Taking this one step further in understanding blood flow visualized on OCT, the left is basically repeated OCT B scans, subsequent B scans, have areas of hyperechoic exposure, echoic from echo sound, which appear like twinkling lights, and these are areas of blood flow. The OCTA uses the algorithms to combine data points into our first non-invasive look at the microvasculature of the eye. Very exciting. And the OCTA used on a patient, you can see here in a neovascular age-related macular degeneration patient. Here you can see the areas of blood flow that can be difficult to separate from artifacts, but the OCTA uses basically probabilistic algorithms to separate the true signal from the noise. And the velocities is unable to be determined from the subsequent B scan, so that's a limitation, and that's why I've set this forward here. So it's possible to assess the position of the microvasculature, which you can see here, but not the velocity in the blood flow. And it's important that the audience realizes this. So visualization of in A on top, you can see a sample of 3D OCTA volume. B on the right side shows you the 2D en-face angiogram. C shows you basically the different retinal layers, and D is the depth color encoded map. Looking at the retinal choroidal vasculature anatomy and where the measurements are done, in this image we can compare the scans obtained to the optometry, to the anatomy. Specifically, different pathologies can be found by isolating specific layers of the microvasculature. And you can see the top right is the superficial vascular plexus where we can measure, but also the deep vascular plexus, which what makes this tool so exciting and being able to look at different layers. Here you can see very nicely the summary of the OCT principle of operation. Basically, the OCTA visualizes vasculature by detecting motion contrasts for moving blood cells. Repeated B scans, N1, N2, and 3 are acquired from the same retinal location, and differences or decolorations between successive B scans are calculated. So OCTA utilizes X, Y, and Z axis to render three-dimensional OCT scans, which are evaluated by the software to detect movement, which is a surrogate of blood flow. I would like now to examine the evidence of how OCTA may be helpful in glaucoma, in diagnosis, in progression, and maybe also in prediction. This is some of the very first studies on OCTA, and that's why I bring it out first. This is a paper in Biomedical Express by Gia looking at quantitative OCTA of the optic nerve head, one of the very first papers. And it shows you very nicely a normal patients here in A, looking at the disc photographs. And then this is A and C from a normal individual as well as a perimetric glaucoma individual. And then looking at B and D, you basically see the on-face OCT angiograms of the optic nerve head, which is representative of these two individuals. And you can see that in B and D, basically you can see the solid circles, and these indicate, the red solid ones, they indicate the whole disc. The dashed circles indicate the temporal ellipses, and the dense microvasculature network visible on the OCT of the normal disc in B versus the attenuated network in the glaucomatous disc in D. And this is set the stage of trying to see and find that and report that OCTA can be a useful tool in helping us understanding glaucoma. This is again one of the early papers in 2016, but this time we're putting together the structural and functional factors. They looked at changes in optic nerve head, vascularization in glaucoma using the spectral domain OCT angiography, 50 glaucoma patients, 30 normals, and looking at vessel density and temporal disc vessel density in optic nerve head. Also, clinical data was used, the visual fields, spectral domain OCT, retinal nerve fiber layer, the GCC, as well as the rim area recorded as well. This paper was published in Journal of Ophthalmology in 2016. This was very fascinating in those days to find the association between the rim area on the x-axis and the temporal disc vessel density and the total optic nerve head vessel density. So temporal disc vessel density and total, and it shows you very nice linear regressions suggesting that the structural changes are indeed associated with the vascular changes. You know, when I started this close to 30 years ago, the question always came up as far as the association or relationship between the vascular changes and the actual structural changes in the nerve fiber layer, in the optic nerve, cup to disc ratio, rim area, in glaucoma. And the reason that this data is so interesting and exciting is that we definitely see that the two are tied together. So all those population-based studies that have suggested that perfusion pressure is important in glaucoma are now met with data that ties in structure. Another one of the other earlier papers from Weinreb's group in IOVS in 2016 looked at comparing OCTA in a cohort of healthy and glaucoma suspects, but also in glaucoma patients. So 3 groups, healthy, suspects, and patients. The purpose was to characterize the relationship between the visual field, the vessel density, and structure in retinal nerve fiber layer thickness. They looked at 260 eyes of 164 participants, and visual field and mean sensitivity recorded. This slide shows you healthy individuals on the left from top to bottom, glaucomatous suspect, and glaucoma patients. Fascinating due to the associations they found between flow or vascular changes, structure and visual field. OCTA vessel density, VD, demonstrated similar diagnostic in their hands, similar to the assessment of structure of retinal nerve fiber layer measurements for differentiating between who is healthy and who is glaucoma. So these were the early studies that have really suggested that OCTA plays an important role as it relates to structure and function in glaucoma. And here what I've done, I've outlined many different studies that have been published on OCTA for the benefit of this audience. And you can see studies in 2014, reduced disc flow index correlated with function and rim area. And you can see that the lower vessel density, as I said before, lower peripapillary vessel density and whole image vessel density were associated with glaucoma. As we move along, again, several other reports also suggest, for example, that in this case, optic nerve head, the paper by Gahara in 2019, and macular vessel density was associated with severity of visual field damage and glaucoma, and advanced primary open-angle glaucoma. I mention this one specifically because lately we have been, it's been suggested that changes in glaucoma, early changes could be maybe detected at the macular, maculary level, and this is another indication to that. Papers in 2019, this paper by Lin is interesting because, again, it suggests that microvascular dropout correlated with decreased retinal nerve fiber, this time in normal tension glaucoma patients. We know that the abnormal vascular appearance and dropout of capillaries has been suggested more so in normal tension glaucoma. That's why I bring up that paper. And another paper, Bayek, in 2019, this time adding another dimension, diurnal fluctuations or diurnal changes of retinal vessel density and mean ocular perfusion pressure are related to glaucoma. So not only the fixed or steady measurements that we get at any given time, but actually the fluctuations, the diurnal changes. Interesting paper. Then papers were published in, continue to be published. I wanted to suggest to you that we have some nice paper that suggests that low density, like the paper by Rao, low superficial vessel density with OCT was significantly associated with faster visual field progression in glaucoma. So this time we have studies that are suggesting that it's actually has related to the progression and long-term studies. Another long-term study is a study by Sale, only in 2023, very recently, suggesting that peripapillary vessel density decreased significantly in the affected hemiretina compared to that in the intact hemiretina in glaucoma eyes with a single hemifield retinal nerve fiber layer detection. Again, as I suggested, we need more longitudinal studies, and this is one limitation, but we're definitely accumulating them. Other studies that perform meta-analysis also focus on the importance of OCTA and vessel density changes in glaucoma that varied in different studies between 0.0036 per year to 1.08 per year, 1.3% and 3.2% per year. But it definitely suggests that these are changes that you can see over time, that there are significantly different rates in visual density change between glaucoma and healthy controls. So you see that it changes in glaucoma with progression, and you see that it changes, or there are differences between glaucoma and controls, and that vessel density changes after surgery. Variable results, we are not sure, ranging from temporary visual density decrease to increase after 3 months. So I think we are still not certain what is going on using OCTA after surgery. This is my paper, and I think it's especially helpful for this course on OCTA. It looks at vascular biomarkers using OCTA and glaucoma, and it concluded by saying that there are significantly decreased vessel density in the optic nerve itself, specifically in the peripapillary vascular layer, as well as in the macula of glaucoma patients compared with controls. and that OCTA vascular biomarkers alongside clinical structural outcomes may aid in assessing overall risk for glaucoma patients. This is new data from Mount Sinai. Specifically, I want to give credit to Toko Chui, and the slides are courtesy of her, working in our institute. And basically, what you can see here is a basically structure function vascular density using OCT modality. On the upper image, you see the loss of the superficial RPC and layer, and revealing the deeper vascular network due to severe retinal nerve fiber layer thinning, A1, and that corresponds with diffuse visual field defects, A2 and A3, and retinal nerve fiber layer thinning in A4. The middle OCTA shows loss of RPC layer superiorly, inferior temporally, and inferiorly, as you can see in B1, somewhat corresponding to superior hemifield defect in B2 and B3, and prominent retinal nerve fiber layer thinning in the inferior region with borderline values in the other regions, which is B4. So the inferior OCTA now shows loss of the RPC layer, superficial and supertemporal. You can see that in the C1, of course, C1, the lower, corresponding to the inferior arcuate defect, C2 and C3, and retinal nerve fiber layer thinning superiorly and superior temporally, C4. So this is a beautiful illustration where OCTA is, this is work in our institute by Toko. Dr. Choi is connected to visual field and structure. This is was also presented in ARVO, and it shows you the lamina cribosa pore area, the neuroretinal rim area, and the peripapillary capillary layer as a function, looking at glaucoma versus controls, as a function of the area, looking at the density as well as the actual vascular area. And in glaucoma group, the lamina cribosa area was significantly larger than the control group. Of course, the neuroretinal rim area and the peripapillary capillary density were found reduced and significantly lower to the control group. So here you can see how the actual structural areas, the lamina cribosa area, the neuroretinal rim area, and the pericapillary density are different between glaucomas and controls, specifically adding the information to the body of knowledge of the peripapillary capillary density. These are 27 controls and 20 glaucoma patients, moderate to severe, that were imaged. This is to remind me that OCTA can be used not only in glaucoma. This is a study by Fard that suggests when you look at the OCTA in healthy control on top, AION, non-arteritic ischemic optic neuropathy, and primary open-angle glaucoma in the bottom, looking at OCTA capillary segmentation and OCTA color density map overlay. And you can see that basically peripapillary capillary density in NION and moderate and severe glaucoma eyes were significantly decreased compared to unaffected fellow eyes and control eyes. So indeed, we focus on glaucoma, but you can see the structural function differences in NION as well. So far, we have looked at the importance of OCTA in being able to basically look at vascular changes, vascular density, vascular perfusion density in glaucoma patient, and related to structure and function. Again, we are hoping to see more longitudinal data. But here we can see that OCTA may be able to help us detect some systemic disorders. This is a very elegant study by Lim, looking at changes in ganglion cell inner plexiform layer thickness and retinal microvasculature in hypertension patients, meaning patients with elevated blood pressure. The top is a healthy subject, ABC, basically looking at vascular density, perfusion density, and the foveal avascular zone. And here's a patient with 10 years of hypertension who had no other systemic or other abnormalities. And you can see that these vascular changes and enlarged foveal avascular zone, as well as basically lower perfusion density and vascular densities, okay, are corresponding to the structural changes, specifically the ganglion cell inner plexiform layer as detected by the OCTA. So can we, should we use OCTA as an indication of hypertension? Or also, do patients with hypertension need to be followed more closely for vascular abnormalities in the eye that could contribute to the glaucomatous damage? And this is another very elegant paper by Chua looking at relationship of quantitative retinal capillary network and myocardial remodeling, again, in patients with systemic hypertension, published in the Journal of American Heart Association. Basically, the OCTA was used in conjunction this time with cardiovascular magnetic resonance, or known as CMR, to compare microvasculature and cardiac remodeling. So we got measurements from the eye and from the heart. The first two boxes are from the OCTA, examining superficial capillary density map and perfusion heat map. The last three are left ventricular short axis view, which shows us on top remodeling, extracellular volume map, higher extracellular volume map, suggesting less ventricular function. And this global longitudinal strain map, which shows you that it's sort of less sharpened at the peak of it, right here, compared to this one below. The top patient shows no, the top patient shows abnormal vasculature as it relates to the perfusion heat map, and the superficial capillary density map compared to the lower patient. So this patient that demonstrated vascular abnormalities in the OCTA had corresponding changes, remodeling in the left ventricular, as you can see, left ventricle, as you can see by the left ventricular short axis view remodeling here, and more and higher extracellular volume map, and also seen with a global longitudinal strain as well. So they examined 118 patients with essential hypertension, and it's clear that the superficial capillary densities are lower in the first hypertensive patient, A and B, as I said, to summarize, and these were correlated with lower remodeling index, C, higher interstitial volume and extracellular volume fraction, D, and worse global longitudinal strain as measured by left ventricular systolic function in E. So, summary, again, the vascular changes picked up by OCTA correspond to left ventricular function. Can they be used to predict them? Should we be observing vascular abnormalities in patients that have left ventricular cardiac dysfunction? as well, that's another question. And just to show their data, which strongly suggests that superficial capillary density on the left, on the y-axis, corresponds again with the index left ventricular mass, index interstitial volume, and global longitudinal strain. With hypertension, you can see that these are correlated strongly. In patients with hypertension, correlations between retinal capillary density and adverse cardiac remodeling markers. OCTA may provide a non-invasive index on microcirculation alteration for vascular risk stratification. Bringing this together, I really appreciate your attention. What I tried to show you today is to have another level of support to something that we've been claiming for decades, and people ahead of me for over 150 years. There's this important role of ocular blood flow in the pathophysiology of glaucoma, most definitely. Optical coherence tomography is being shown to be a useful tool to elucidate the pathophysiologic mechanism of glaucoma. There is still a need for confirmation of longitudinal studies to evaluate clinical applicability of OCTA for glaucoma diagnosis, follow-up, and prediction. OCTA could also be a tool to predict cardiovascular damage and systemic disease from ocular biomarkers, but we need much more work on that. And in the future, what we are doing, as you can see, we just have received a new NIH grant, a smart eye emulator to study glaucoma risk factors, together with Giovanna Guidoboni. We are basically using mathematical models and artificial intelligence alongside tools like OCTA to see if we can predict glaucoma progression. Again, I want to thank the Indian Glaucoma Society, Ophthalmological Society, and CIPLA for putting this together. It was a privilege and honor to talk to you yet again. Thank you so much.